Welcome to the deep dive. Today, we're tackling a topic that's, well, absolutely crucial for improving healthcare right now. How we use data to make things better for patients. We know you're busy, you're probably bombarded with information, and honestly, healthcare data can feel like a massive, confusing puzzle sometimes.
It truly can. I
Yeah.
mean, just think about the sheer amount of information generated every single day. You've got electronic health records, constant monitoring devices. It's huge.
An incredible resource, really.
Absolutely. But only if we can, quickly and effectively turn that raw data into real insights that actually lead to positive change.
And that's precisely what we're aiming to do in this deep dive. We've looked at some really valuable material for you. We've got key sections from advanced data analysis and quality improvement in healthcare.
Good stuff in there.
Some background on the work of Dr. Mazen M. Salama, and important insights from comprehensive management of information in healthcare. So, our mission here is to pull out the essential knowledge. How to use advanced data analysis, information management, all focused on improving healthcare quality. We want to look at what works in practice and what's new.
Focusing on the practical applications, that's key.
Exactly. Okay, let's dive right into this idea you mentioned, this data deluge in healthcare.
Yeah, it's a flood, no doubt about it. Every time a patient sees a doctor, has a test, even just gets their blood pressure checked at home with a smart device, more data is created.
Constantly accumulating.
Constantly. And the real trick is how we take all those, individual pieces and organize them so they tell a meaningful story, a story that helps us provide better care.
And that's where having a good structure comes in, isn't it? It's not enough to just have all this information sort of floating around.
Exactly. Without a systematic way to manage it, data just sits there. It's inert. Effective data management, well, it provides the roadmap. It lets us make evidence-based decisions and, really importantly, drive those improvements in the quality of care patients receive.
It helps us be proactive, not just reactive.
Precisely. We can move from just reacting to problems as they pop up to actually identifying and preventing them before they happen.
You know, something that always reminds me of the importance of good data is that old saying, garbage in, garbage out.
Ah, yes, classic.
It's a bit blunt, but it really highlights that the quality of our insights, well, it depends entirely on the quality of the data we start with.
That's a fundamental truth in this field. The conclusions we draw, the improvements we make, they're only as reliable as the information we're analyzing.
So timeliness, standardization, that becomes critical.
Incredibly important. This is where things like interoperable electronic health record systems, systems that can actually talk to each other, become so vital.
Right, breaking down the silos.
Exactly. And standards like HL7, which basically provide a common language for exchanging that data.
So, okay, what are some concrete actions healthcare organizations can take to make sure they're working with good quality data, not the garbage?
Well, there are several key steps. First, establishing clear, consistent timelines for when data should be submitted. That's crucial. Imagine trying to make a decision based on lab results that are days old.
Could have serious consequences.
Definitely.
Yeah.
Second, using standardized terminologies. Things like STUMDCT and LOINC. Think of it like having a universal translator for healthcare data.
Ah, so everyone's describing things the same way.
Precisely. It ensures everyone is using the same language for conditions, procedures, lab results. Makes the data much more consistent and comparable, across different systems, different organizations.
That makes perfect sense, speaking the same data language. But even with those systems, human errors can still creep in, right? People are still typing things in.
Absolutely. We're all human. Mistakes happen. That's why having robust data quality assurance measures is essential.
Like what, specifically?
Well, things like automated checks built right into the systems, kind of like spell check to catch errors as they're being entered. Regular data audits to proactively look for inaccuracies or missing info. And crucially, ongoing training for staff, helping them understand the importance of accuracy and minimizing those manual data entry errors in the first place.
Right, constant vigilance. Okay, so we've got this data. Hopefully it's high quality. What's next? It doesn't just magically tell us what we need to know, does it?
Not at all. The analysis process itself needs to be carefully thought out, and really importantly, it needs to be a team effort.
Not just one person in a back room crunching numbers.
Definitely not. This isn't something that should happen in isolation. It really requires collaboration. You need the clinicians who understand the patient care process intimately.
The boots on the ground.
Exactly. You need data scientists who have the expertise to apply the right analytical techniques. And you need the quality improvement professionals who are focused on, well, making things better.
That multidisciplinary approach sounds vital. Different people bringing unique skills to understand what the data is really saying.
It is. Everyone sees a different facet of the picture.
So what are the typical stages in this analysis journey? How does it unfold?
Typically, it starts with gathering and doing an initial review of the data. This might be quality professionals, maybe departmental teams.
Getting the raw stuff together.
Right. Pulling the raw data, creating summaries, often using dashboards or basic statistical software, just to get a first look at performance, see if anything jumps out.
And then?
The next stage is more in-depth interpretation and analysis. This usually involves teams like, say, quality councils. This is where they dig deeper.
Looking for the patterns.
Exactly. Looking for patterns, trying to draw conclusions, developing recommendations. Sometimes this stage might even involve more advanced analytical techniques, things like machine learning to uncover complex relationships or maybe predict future outcomes.
Okay, so we have good data. It's being looked at by the right people working together. What are the key questions this whole analysis process is actually trying to answer? When it comes to improving healthcare, what do we need to know?
Yeah, these are the fundamental questions that drive improvement. Things like, how are we actually performing on the key things we measure? Are we meeting the goals we set for ourselves?
The basic check-in.
Right. And are we truly meeting the needs and expectations of our patients and their families? Looking at satisfaction surveys or maybe patient-reported outcome measures PROMs.
What the patient actually experiences.
Exactly. Then, are the ways we deliver care actually leading to the best possible results? How do we stack up against established medical guidelines?
Benchmarking against best practice.
And how stable are our current processes? Are we seeing consistent performance or is it all over the place? That's where things like statistical process control come in.
Looking for stability. Makes sense, yeah.
And are there specific areas where the data suggests, hey, you need to take a closer look here? Opportunities for improvement we might not have seen otherwise?
Finding the weak spots.
Or the opportunities? And crucially, if we've put a quality improvement plan into place, is it actually working? We need to see the evidence in the data, right? Pre- and post-intervention analysis.
Proof in the pudding.
You got it. And finally, maybe we've introduced a new process, like trying to reduce wait times. Is it actually achieving what we designed it to do?
Those are all really practical, concrete questions, using the numbers to get a clear picture of what's happening and where we can do better. Now, you mentioned some rules for effective analysis a lot. The practical steps. Where do we even begin with that? How do we do it right?
Well, it really starts by clearly defining the questions you want to answer before you dive in and identifying the specific metrics you'll use to answer them.
So have a plan first. Don't just go fishing.
Exactly. You can't just wander through the data hoping to stumble upon something interesting. It's inefficient. For example, if we're focused on improving medication safety, we need to look at specific metrics. Maybe the rate of medication errors or the number of adverse drug events, ADEs.
Only specific.
Very specific. Then, as we sort of touched on, the type of data you have dictates the tools you use. If you have continuous data, like length of stay.
Like a number that can vary smoothly.
Right. You might use regression analysis to see what factors influence that length. But if you have categorical data, like the percentage of patients getting an infection, yes or no?
Like categories.
Correct. You might use something like chi-square tests to see if there are significant differences between groups. Different data, different tools.
And what about the actual software and platforms? Seems like there are tons of options.
Oh, yeah. Lots of powerful tools out there now.
Yeah.
For complex statistical modeling, you see a lot of R and Python being used. They're very flexible.
The programming languages.
Right. Then for creating those interactive visuals, the dashboards we talked about, platforms like Tableau or Power BI are really popular. They make data easier to understand.
More accessible.
Definitely. And for specifically tracking process stability over time, SPC tools, statistical process control with control charts, are invaluable. They help you see if a process is behaving predictably.
And it's not just about looking at our own data in a vacuum, is it? We need some context. That's where benchmarks come in, I assume.
Absolutely critical.
Yeah.
Performance benchmarks provide that context. You need to compare. First, internally, how are we doing compared to our own past performance?
Yeah.
Are we improving?
Looking back at yourself.
Exactly. Then there are external benchmarks. What are the national averages? What are other similar organizations achieving, especially those known for high quality?
Seeing how you stack up.
Right. And of course, you have to consider regulatory standards. What does the Joint Commission or CMS expect? Those are benchmarks too.
You mentioned comparing internally. How do we really dig into our own performance over time?
That internal trend analysis is super useful Control charts, as I mentioned, help identify what's called special cause variation.
Social cause?
Yeah, those unusual spikes or dips in performance that signal something out of the ordinary happened, like a sudden jump in infections that wasn't there before. It prompts investigation.
Okay.
Simpler run charts can also just help visualize the overall trends over time, or things generally going up, down, staying flat. And setting clear targets helps too, like aiming for a specific lower readmission rate. Gives you something to shoot for.
And I think I read something about predictive analytics.
Yes, that's becoming increasingly powerful. Using historical data to forecast potential future trends, it allows us to potentially address issues before they become big problems. Very proactive.
That sounds incredibly useful. And when we do look outside our own walls, how can we best use that external benchmarking data? Data from CMS or nursing databases.
Right, data from sources like CMS Hospital Compare or the National Database of Nursing Quality Indicators, NDQI, that gives us invaluable insight into how we compare to peers.
Finding out where you lag.
Exactly. It helps pinpoint specific areas where maybe our performance isn't as strong as others. Then the next step is crucial. Investigate the practices of those high performers. Can we learn from them? Can we adapt their successful approaches?
Don't reinvent the wheel if someone else has figured it out.
Precisely. Learn from the best.
Now, staying compliant with regulations is obviously a huge part of healthcare. How does data analysis help meet those standards set by CMS or the Joint Commission?
Oh, data analysis is absolutely essential for compliance. You need to regularly review the latest standards, the clinical guidelines from groups like the American Heart Association,
Keep up to date?
constantly. Then you use your own data to assess how well you're actually adhering to these best practices. Where are the gaps? Then you make changes to your processes as needed.
And comparing to peers helps here too.
Very much so. Seeing how others are meeting the same requirements can give you ideas and also show you where the bar is set in practice.
So when we kick off this initial data analysis, who's typically responsible? Does it just happen?
No, it needs structure. Healthcare organizations really need to designate specific teams or individuals. Someone needs to own the initial collection and summary of data. And maybe a different group handles the more in-depth analysis if there
Player roles.
clear roles, clear responsibilities. And it's vital to establish a regular schedule. Is this monthly, quarterly? For some critical things, maybe even real-time monitoring, you need consistency.
And what does that initial review involve?
It should always involve, first, checking the data accuracy, the garbage in problem again, then comparing it to past performance, your baseline, to see if there are significant shifts, and critically, flagging any serious events, sentinel events, or really unusual data points, outliers, that need immediate attention.
Okay, so what kind of events or findings would then trigger that more thorough, intensive investigation? When do you need to dig deeper?
Several things act as triggers. Obviously, any sentinel event, those unexpected incidents causing serious harm, immediately requires a deep dive, no question.
Top priority.
Absolutely. But also, significant statistical deviations. When your performance suddenly falls way outside the expected range, or it's drastically different from your peers, that warrants a closer look.
Like that special cause variation again.
Exactly. Also, any instance of failing to meet a key regulatory requirement or identifying significant safety risks, maybe through patterns of recurring errors, those all demand more intensive analysis.
And the sources mention tools like RCA and FMEA.
Yes, root cause analysis, RCA, and failure modes and effects analysis, FMEA. These are structured methods for systematically investigating why something went wrong, RCA, or proactively identifying potential failures before they happen, FMEA. Really important tools.
Okay, so when we move into that intensive analysis phase, who are the key people involved then? Is it the same team?
Often it expands. This is where that collaborative approach really shines. You'll typically see clinicians with specific expertise in the area being investigated.
The subject matter experts?
Right. Working closely with data analysts who bring the statistical firepower. And often, a broader interdisciplinary team gets involved to make sure all angles are considered: nursing, pharmacy, administration, depending on the issue.
A comprehensive look. And what kind of analytical methods are used in this more detailed investigation? Are they different?
Some are the same, just applied more rigorously.
Yeah.
You'll still see data aggregation summarizing info with percentages, totals, graphs to get a clear picture. Trend analysis becomes even more crucial. Is this a one-off or a pattern?
Digging into the history.
Exactly. And for specific incidents, like adverse events, detailed case reviews or peer reviews are common. But we also see more advanced techniques coming in now.
Like the machine learning you mentioned.
Yes, machine learning can be really powerful here. It can help identify subtle patterns in huge data sets that might be missed by traditional methods. Another exciting area is natural language processing, NLP. Yeah, analyzing unstructured data. Think about all the text in doctor's notes, discharge summaries. NLP can help extract valuable information from that text data, which was traditionally very hard to analyze systematically.
Wow, unlocking insights from notes. Okay, ultimately, what are the desired outcomes? What should happen as a result of all this careful analysis?
The goal is real, tangible improvement, actionable results. This could mean changes to systems like redesigning a workflow to make errors less likely.
Process improvement.
Right. It could lead to better knowledge and skills through targeted staff training on identified gaps or best practices. Or it might result in changes in behavior, encouraging better adherence to safety protocols or guidelines.
Changing how things are done.
Exactly. And the sources also highlight something important. After you implement changes, you monitor. Maybe for 6 months, maybe a year. If things have stabilized and improved, great. But you still reassess. Are these the right indicators now? Is our data collection still optimal?
Don't just set it and forget it.
Never. And of course, document everything. All findings, actions taken. It's crucial for compliance, accreditation, and just organizational learning.
It really sounds like a continuous cycle then, learning and improving constantly. Can you quickly recap the main steps in that cycle?
Sure. It is definitely a cycle. It starts with data collection, getting the info on your key measures, then aggregation and initial analysis summarizing it, getting a first look.
Okay.
Next comes more formal statistical analysis, understanding the variation, then comparison against your benchmarks, internal and external.
See where you stand.
Right. If significant issues pop up, that triggers the intensive analysis, the deep dive we talked about.
Yeah.
And the cycle concludes, or rather continues, with action planning, identifying changes, testing them, implementing them, and then deciding how to measure the impact, which leads back to data collection.
The PDSA cycle, essentially. Plan, Do, Study, Act.
Very much aligned with Deming's principles, yes. Continuous improvement.
Now, all this great analysis is only valuable if the findings are actually communicated and acted upon, right? How do organizations effectively share this information?
That's a critical point. Strong reporting mechanisms are crucial. Performance data needs to be regularly shared upwards with governing boards, often through quarterly or annual reports summarizing key events, sentinel events, major QI initiatives.
Keeping leadership informed.
Absolutely.
Yeah.
But it also needs to be shared effectively with staff through meetings, dashboards, newsletters, whatever works to ensure everyone is aware of performance and feels engaged in making things better.
And confidentiality.
Paramount. Throughout this entire process, protecting patient and practitioner identifiers is absolutely vital. Anonymizing data where appropriate, adhering to HIPAA and other privacy rules.
And are there new trends in how this info is shared?
Yes, definitely. We're seeing much more use of real-time dashboards, giving people access to up-to-date performance data. And automated reporting systems are becoming more common, which helps with efficiency and consistency.
Getting the info out faster.
Exactly. And ultimately, this quality data shouldn't just live in the quality department. It needs to be integrated into the very fabric of the organization. It should inform strategic planning, risk management, even financial planning and resource allocation.
Making quality central to everything.
That's the goal.
Let's shift slightly to transparency. That word comes up a lot. What does it really mean in this context, and why is it important?
Transparency in healthcare generally means making information about the cost and quality of care publicly available, so patients, employers, everyone can see it.
Opening the books, so to speak?
In a way, yes.
Oh.
And its role, well, studies suggest it can help reduce those sometimes huge variations in prices for the same service. And, perhaps more importantly for our discussion, it can incentivize providers to improve their quality. If your performance is public, you're more motivated to make it good.
Makes sense. Public accountability. But are there challenges?
Oh, definitely. Getting consumers, patients, to actually engage with and use this complex data can be hard. Ensuring the data itself is consistent and comparable across different providers is another big one. And of course, balancing transparency with patient privacy is always a delicate act.
So how can we make transparency better, more effective?
Key strategies include presenting the information in really consumer-friendly formats. Think star ratings, clear infographics, not just dense tables of numbers.
Understandable.
Exactly. Using standardized metrics so comparisons are fair, and leveraging digital platforms, websites, apps to make the data easily accessible when people need it.
Okay, shifting gears again slightly, what about the role of the quality professional in all of this? They seem central.
Absolutely pivotal. Quality professionals are often the guardians of data accuracy. They ensure compliance with standards. They play a huge role in fostering that culture of safety and improvement, ideally, a non-punitive one where people feel safe reporting errors.
Setting the tone.
Yes. And they are often the key advocates pushing for process changes based on the data. They translate the analysis into action. And increasingly, they need to understand how things like AI are integrating into quality improvement.
And there are ethical considerations woven throughout this.
Always. The AMA's Code of Medical Ethics, for instance, touches on things highly relevant here, like disclosing financial factors that might influence care, ensuring patients are informed of all their options, and advocating for policies that promote transparency and equity. Ethics underpin trustworthy data use.
How does public reporting fit into this, like those hospital report cards we sometimes see?
That's a major mechanism for transparency and accountability. Think CMS Hospital Compare, the Leapfrog Group's ratings. These platforms publish performance data using, ideally, standardized metrics.
So everyone's measured the same way.
That's the goal. It allows for comparisons and pressures organizations to improve. Using the public feedback generated from these reports is also important for driving change. We're seeing initiatives like CMS's recent updates to its hospital quality star ratings, emphasizing more patient-centered metrics, which is a positive trend.
Now, one of the key sources for our deep dive was work by Dr. Mazen M. Salama. Can you tell us a bit about his perspective or contribution?
Sure. Dr. Salama is interesting because he brings multiple perspectives. He's the author of resources like the CPHQ certification prep course and comprehensive management of information in healthcare. But he's also a senior clinical data scientist, a cardiologist.
A clinician and a data expert.
Exactly, and founder of Thomas C. and Aditamia. His focus really seems to be on bridging that gap between clinical practice and quality management, using data-driven solutions, making data meaningful and useful for people actually delivering care.
That practical application focus again makes sense. Let's talk about information literacy. It sounds foundational to everything we've discussed.
It absolutely is. Information literacy, basically, is knowing how to find, evaluate, and use information effectively and ethically. In healthcare, it's the bedrock of evidence-based practice. Without it, you can't make sound clinical decisions or quality improvements.
So what are the key skills involved?
Several things. Proficiency with search tools is one, knowing how to effectively use databases like PubMed or Scopus. And now, even AI-powered tools like Semantic Scholar or Cite are becoming important.
Beyond just Googling it.
Way beyond. Strategic search techniques are key too. Using things like Boolean operators, AND or NDT, medical subject headings, many H, keyword truncation, these refine your search. And AI is helping here too with recommendation engines.
Finding the right information efficiently.
Exactly. Then critically, source evaluation. You need to be able to judge the credibility and relevance of information. Frameworks like the CREP test currency, relevance, authority, accuracy, purpose are useful. Prioritizing peer-reviewed sources is generally key. And tools like Cite can even show how research has been cited, which gives clues about its reception.
Checking the quality of the source itself.
Definitely. And finally, ethical and legal compliance. Understanding LIPE for patient privacy, GDPR if applicable, intellectual property rules, getting IRB approval for research. It's all part of responsible information use.
And are there recent advances making this easier or different?
Yes, AI-enhanced search is a big one. Open access repositories like PLOS or DOAJ are making research more accessible. And tools like ResearchRabbit help monitor new literature in real time.
So practically, a clinician researching a rare disease might use PubMed, maybe refine with MASH terms, use Cite to check key paper citations, and ensure they handle any patient data involved according to IPAY.
That's a great example of information literacy in action.
Okay, let's move to data management itself. We talked about the deluge. Where does all this data actually come from?
It's incredibly diverse. Electronic health records are a huge source, obviously. Wearable devices, fitness trackers, continuous glucose monitors, clinical registries like cancer registries, billing and administrative systems, public health databases, patient surveys. The list goes on.
And how is it collected? Is it all automated now?
A lot is increasingly automated. Think IoT devices in hospitals constantly sending data, or barcoding systems for medications and supplies. RFID tags, too.
It's reducing manual entry.
Right. But surveys and registries are still vital, collecting things like patient-reported outcomes, PROs, or detailed clinical data. Mobile apps like RECAP are often used here. Manual data entry still happens, of course, and it has limitations potential for errors, time-consuming. Mitigation involves clear protocols, training, and validation checks.
And Ethical considerations around collection.
Huge. Informed consent is paramount ahead. Patients need to understand how their data will be used. Anonymization techniques, like the safe harbor method, are used to protect privacy. An institutional review board, IRB approval, is typically needed for research involving human subjects' data.
So once we have this raw data, how does it become useful information?
That's the transformation process. First, cleaning the data, dealing with errors, missing values, inconsistencies. Tools like OpenRefine or programming libraries like Pandas and Python are common here.
Getting it ready.
Exactly. Then aggregation, combining data from different sources, followed by analysis, applying statistical methods or machine learning to find patterns and insights. Then visualization, using tools like Tableau, Power BI, or code libraries like Matplotlib to create charts and graphs that make the findings understandable.
Telling the story with data.
Precisely. The goal is to demonstrate outcomes, identify trends, and support decision-making.
Any recent innovations changing this process?
Yeah, quite a few. Blockchain is being explored for enhancing data integrity and security. Predictive analytics are getting much more sophisticated for forecasting outcomes, like sepsis risk in ICUs. And techniques like federated learning allow models to be trained across multiple locations without the raw data ever leaving those sites, which helps with privacy.
Like a hospital using real-time ICU data and predictive models to flag patients at high risk of deteriorating.
Exactly. That's a powerful application happening now, potentially reducing mortality.
We touched on this, but let's explicitly state the difference. Data versus information. Why is it so important?
It's a crucial distinction. Data is just raw facts, numbers, symbols, without context. Like we said, a single temperature reading, 99.5 degrees Fahrenheit. That's data.
Just a number.
Right. Information is data that's been processed, organized, structured, or presented in a given context so as to make it useful. So that 99.5 degrees Fahrenheit reading, when combined with previous readings showing a rising trend over hours and linked to a specific patient with symptoms, that becomes information suggesting a fever.
Context and meaning.
Exactly. And you need valid data to create reliable information. Valid data is crucial for establishing best practices, identifying gaps in care, supporting policy decisions, everything we've been talking about.
And statistical validity comes into play here.
Yes. Concepts like adequate sample size, randomization in studies, using confidence intervals, these help ensure the data can reliably support the conclusions drawn from it. You need statistical rigor.
Like a hospital using surgical site infection, or SSI, data. If the data is validly collected and analyzed, they can confidently link specific protocols to reduced infection rates.
Perfect example. Valid data leads to credible information, which leads to effective action.
What about the guiding principles behind all this information management? What are the main goals?
The overarching objective is usually to generate actionable insights that support better decision-making, improve processes, and ultimately enhance patient outcomes and organizational performance.
And frameworks like Deming's TQM.
Absolutely relevant. Deming's emphasis on data-driven decisions, continuous improvement cycles like PDSA, understanding processes, systems thinking, these are all core tenets of effective healthcare information management.
And how does the financial side integrate, especially with things like value-based care?
It's deeply integrated. Information management helps analyze cost effectiveness, comparing outpatient versus inpatient costs for a procedure, for example. It's essential for optimizing reimbursement under value-based payment models, where you get paid for quality and outcomes, not just volume. And it informs resource allocation. Where should we invest to get the biggest improvement?
But there are challenges, too.
Oh, yes. Data silos where different systems don't talk to each other remain a huge challenge, though standards like FHIR are helping.
Yeah.
And just sheer data overload, figuring out what's important in the noise.
Let's talk about the systems themselves, the healthcare information systems. What are the main types?
Broadly, you can think of three categories. First, administrative information systems, or AIS. These handle the business side financials, billing, HR, risk management, sometimes quality reporting. Think systems like SAP Health. They focus on efficiency, reporting, automation, compliance.
Well, back office stuff?
Largely, yes.
Ah.
Second, clinical information systems, or CIS. These are patient-centric. The big one is the electronic health record, EHR. But also PayCS for imaging, pharmacy systems, lab systems. Epic Systems is a major player here. Features include clinical decision support, medication reconciliation, integrating diagnostic results.
Where the care happens.
Exactly. And third, decision support systems, or DSS. These often combine data from both AIS and CIS, maybe with external data or advanced analytics, to help with complex decision-making. Think IBM Watson Health. They might do risk stratification, predicting patient outcomes, or modeling scenarios.
Bringing it all together for insight, are there challenges in implementing these?
Definitely. DSS adoption can be slow to roast. Clinicians need to trust the recommendations. Cost is always a factor. And data quality issues in the underlying systems can undermine the effectiveness of any DSS built on top.
And recent developments.
Huge shift towards cloud-based systems using platforms like AWS or Azure offer scalability and sometimes lower upfront costs. AI is being embedded much more deeply into DSS like Google Health's work, and interoperability continues to be a major focus, with FHIR and related standards like SMART on FHIR gaining traction.
Could a hospital use a DSS to analyze readmission data, identify high-risk patients, and trigger targeted interventions, potentially reducing readmissions and associated costs?
That's a classic DSS use case, and many hospitals are doing exactly that, often showing significant returns.
What about managing aggregate data, looking at groups, not just individuals?
That's essential for understanding trends in population health. The process involves aggregation, pulling data often into data warehouses or data lakes, using platforms like Snowflake or BigQuery, then summarization, calculating statistical measures like means, medians, percentages for groups, and defining timeframes, looking at data daily, weekly, monthly, or via real-time dashboards.
And visualizing this aggregate data.
Crucial for making it understandable. We use graphical displays, bar charts, line graphs, showing trends, heat maps, sometimes more complex ones like Sankey diagrams for flows. Tools like Tableau, Power BI, or coding libraries like D3JS are used. Best practices are important here, things like using colorblind-friendly palettes, clear labels, avoiding misleading scales.
What's the impact of looking at data this way?
It drives quality improvement tracking infection rates across units, for example. It helps identify best practices, maybe seeing which rapid response teams have the best outcomes. And it's key for engaging stakeholders, showing leadership or the public how the organization is performing overall.
Like a hospital aggregating fall data, visualizing it by location and time of day, and then implementing targeted prevention strategies in high-risk areas.
Exactly. Using aggregate data and visualization to pinpoint problems and track the impact of solutions.
So, tracing the path, data becomes information, then knowledge, then decision-making. What are the risks if that chain breaks down due to poor data?
The risks are significant. Decisions based on biased or inaccurate data can lead to inefficient resource allocation, ineffective treatments, perpetuate health disparities, and, in the worst case, cause direct patient harm.
Serious consequence.
Very serious. Strategies to ensure robust data are therefore critical. Things like data standardization using common data models like WOLP helps, rigorous data validation processes, and comprehensive user training.
Could you give an example, like with medication errors?
Sure. A hospital might collect data on medication errors. If the data is poor, incomplete, or inconsistent, they might miss critical patterns. But if they have robust data, they can analyze it, identify that most errors happen during reconciliation at discharge, implement an electronic reconciliation tool, train staff, and then use ongoing data collection to demonstrate a reduction in those specific errors.
Closing the loop with good data.
That's the idea.
We hear terms like sensitivity, specificity, benchmark. Can you clarify some of these key data definitions and metrics?
Absolutely. These are fundamental for understanding data quality and performance. Sensitivity measures how well a test identifies true positives, people who have the condition. Specificity measures how well it identifies true negatives, people who don't have the condition.
So high sensitivity catches most people with the disease.
Right. High specificity correctly rules out most people without it. There's often a trade-off.
Okay. What about stratification?
Stratification means dividing data into subgroups, like analyzing outcomes by age group or gender or insurance type to see if there are differences. It helps uncover disparities or identify specific populations needing attention.
And usability, recordability, validity, reliability.
Usability refers to how easy the data is to access and understand. Recordability is about how consistently and easily the data can be captured. Validity, as we discussed, is about accuracy. Does it measure what it's supposed to? Reliability is about consistency. If you measure the same thing again, do you get the same result?
All important aspects of data quality. And performance metrics like goal, trigger, threshold, benchmark.
A goal is the desired level of performance. A benchmark is a standard to compare against, internal or external. A threshold might be a minimum acceptable level, and a trigger is a specific level or event that requires action or investigation, like if an infection rate exceeds a certain percentage.
Can you give a quick example calculation for sensitivity specificity?
Sure. Imagine a test for disease. Out of 100 people with the disease, the test correctly identifies 90. Sensitivity is 9100 equals a 90%. Out of 200 people without the disease, the test correctly identifies 180. Specificity is 100 and 290%.
Got it. And there are more advanced ones like PPV, NTV.
Right. Positive predictive value, PPV, tells you if you test positive, what's the probability you actually have the disease. Negative predictive value, NPV, tells you if you test negative, what's the probability you don't have the disease. These depend on the disease prevalence in the population, unlike sensitivity specificity. AUC, area under the curve, is another metric often used to evaluate the overall performance of diagnostic tests.
Okay, that helps clarify those terms. What about a data inventory? What is that and why do organizations need one?
A data inventory is basically a catalog of an organization's data assets. Its purpose is to make data easier to find, understand, and use appropriately. It promotes data governance.
Knowing what you have and where it is.
Exactly. It typically includes things like clear data definitions, where the data comes from, source systems, who owns it or is responsible for it, what analysis methods are typically used on it, and any protocols for sharing it.
How do you actually implement one?
It requires collaboration across departments. Training is needed so people understand its importance. Technology helps specialized data catalog platforms like Elation or Calibra are designed for this. And it needs ongoing maintenance, regular updates, maybe led by the quality or data governance department. It's not a one-time project.
What challenges does it help address?
It tackles data silos by making data visible across the organization. It can help reduce redundancy, multiple departments collecting the same thing. And it combats the DRIP syndrome, data-rich, information poor, by making existing data more accessible and understandable.
Are there recent tools making this easier?
Yes, the data catalog platforms I mentioned are becoming more sophisticated, using AI to help automate the discovery and tagging of data. AI-driven data governance tools are also emerging. And data lakes provide a central place to store diverse data, which can simplify inventorying.
So a hospital might create an inventory, realize they have 5 different departments sending out similar patient satisfaction surveys, and use that insight to consolidate and streamline the process.
That's a classic benefit, reducing survey fatigue for patients and getting more consistent data.
Looking ahead now, what are the major emerging trends we should be watching in healthcare data and information management?
AI and machine learning are huge, obviously. We're seeing more sophisticated AI in clinical decision support, using tools like DeepMind. Natural language processing is advancing rapidly. And generative AI, like ChatGPT, is starting to be explored for tasks like summarizing notes or even drafting patient communication, though with caution.
Interoperability still a big focus.
Absolutely. Wider adoption of FHIR standards is key. Things like SMART on FHIR, which allows apps to plug into EHRs more easily, are gaining momentum. Making data flow more seamlessly is still a major goal.
What about patient data?
Big shifts there. More integration of patient-generated data from wearables and PROs, and growing discussion around data ownership and control, with technologies like blockchain being proposed to give patients more agency over their health information.
And security must be evolving too.
Constantly. With more data comes more risk. We're seeing adoption of cybersecurity frameworks like zero-trust architecture. And looking further out, even quantum cryptography is being researched to counter future threats.
It's clear this field is moving incredibly fast. This has been a really insightful deep dive into how we leverage data for quality improvement. It's complex, but as you said, the potential impact is huge.
It really is. It's challenging work, requires constant learning, but it's fundamental to building a better, safer, more effective healthcare system.
So for you, the listener, as you reflect on this, think about how transforming raw data into actionable knowledge isn't just a technical exercise. It's about empowering clinicians, engaging patients, and driving real change.
It underpins so much of modern healthcare improvement.
And here's something to perhaps mull over. As patient-generated health data becomes more integrated, how might this shift the traditional dynamic between patients and providers? What new opportunities, but also what new ethical considerations will arise when patients arrive with their own detailed health data dashboards?
That's a fascinating question for the future. It implies a real partnership model.
Indeed. We encourage you to keep exploring these topics. The resources we mentioned are great starting points. Thank you for joining us for this deep dive.
Thank you.